why it was important to know what you can find the lateral acromion. Your axis of rotation, you're going to find your lateral acromion, the lateral border of it, and then you're just going to fall off just inferior. So the point of all your axes of rotation is that when you're inferior to it, you're going to be right through the humeral head. So just like anything else, you want to be from the axis of rotation of the joint. So you're going to be through the axis of rotation of the gunal humeral joint, which is just inferior to your lateral acromion. So you're projecting through your humeral head going toward the glenoid. So that's going to be your axis of rotation. Your stationary arm is going to be parallel to the trunk, which we will see better over like that, right? So it's going to be parallel to the trunk. And your moving arm is going to be going toward the midline of the humerus, toward your lateral epicondyle, right? Make sense? So the one thing that we need to know for flexion and extension and a couple other shoulder motions is that you're going to lose your access when you're doing this. So we're going to pin it to the table. So you're actually going to just hold it like that off the body. You're not going to hold it here onto the body, because when she moves, the axis is going to be completely gone, and if you're trying to follow it, you're going to be in the wrong spot, okay? So you're going to palpate your lateral acromion. You're going to move inferior to it, going through the humeral head, line up your stationary arm parallel to the trunk and the table, and then you're going to move her, keeping your axis in the same spot. So I just plant it to the table, and then you move her, go to end feel, align your moving arm to the middle line of the humerus, to the lateral epicondyle, and you take your measurement, which you guys will know from your AAOS, and you don't have to worry about getting further like you do for knee extension whenever she goes to the table. As long as she hits the 180, you don't have to be concerned. We don't usually document the excess motion for the shoulder, right? Anyone disagree? Right? I don't think we do. In the clinical world, you would just document it, however, how you did with knee extension, where you just indicated that it was past 0 or from 5 to 0 to 135, whatever for the knee. You would do the same kind of thing. You would document the overall excursion. But for this class, you only have to document that she got to 180. So if you see that she's past 180, you could say that she achieved full range of motion, 180 degrees of shoulder flexion. We're not going to ask you to tell us how much more. So you don't have to worry about like propping her up on a pillow or anything. Key points, you want to bend the knees. Joanne, bend your knees for me. She has to be very flexible so it doesn't affect her, because you're not going to see any arching of her thoracolumbar spine in Joanne because she has good motion in her shoulder. But for somebody who's tight and you're trying to come to full shoulder flexion, you're going to see the back arch, because they're at their end range of motion of the glenohumeral joint, and they're starting to compensate in their body, in their thorax. So the knees are bent. You're looking for the thoracolumbar extension. Those are the compensations. You want to be in what plane? What plane does shoulder flexion occur in?
Sagittal.
Right. So you want to be in the sagittal plane as you do it. So what you want to make sure of is that you're not out here or too abducted, okay? So you want to be right in the sagittal plane, parallel to the body. Any questions on that so far? Okay. For extension, you want to make sure that they're right at the edge of the table. Does Bill use a towel for this one? This picture? No? Okay. Just make sure they're at the edge of the table, so that they have motion to get off the side. You can even come a little further for me. Good. The reason for that being is you want the glenohumeral joint to be able to extend past the table without having to abduct the arm. One of the common things on the practical a lot of people do, they're too far over to the other side, they're trying to abduct the arm, and they end up coming on this scapular plane kind of motion. So be further enough off that you can fully extend. You have your same axis. You can line it up, and stationary arm, keep it there. Your moving arm, same location, middle line of the humerus. And when you do this, you want the elbow a little bit bent. Does that make sense? I think he indicates why. Does anybody remember why? Bicep length, right? It's a two-joint muscle, so if your arm is fully extended, your bicep is on stretch, and it's going to limit your shoulder motion. So basically, you'd be testing bicep length. You wouldn't really be testing glenohumeral joint extension or hyperextension. So patient starts here. As with everything, you're always asking for active first, then you're going to go into your measurements, okay? So she does active range of motion extension first, and then you take your measurement, you line it up, and you line up your goni parallel to the body, access midline of the, just inferior to the lateral acromion, going through the middle of the humerus to the glenohumeral joint, and your moving arm is toward the lateral epicondyle of the humerus. You check end feel, you make sure there's no what now, what's gonna be your compensation. What's that? abduction of the shoulder with the glenohumeral joint. She may flex her thoracic spine slightly. She's trying to get her arm to go behind her a little bit. Internal, external rotation of the shoulder, right? And you take your end feel and you get your measurement. Okay? Any questions on those so far? Stationary arm is parallel to the trunk, or parallel to the floor. You use something different in there?
It says decision arm, just not.
What's that?
Picture is not running.
No, it says axillary of trunk.
Yeah, it's the same as above, and for above, it's
Yeah, in other words,
midline
this is
axis.
centered in the picture. So guys, the picture in your book, Bill's trying to say, is wrong. Got it? In order for you to see it, you can't do it like that. So he's saying that person in that picture would have lost points for what that person's doing.
Right. And mid-axillary line, guys, just means like where it would intersect the axilla. Basically saying that where the middle of the axilla or the
You're on the
armpit
camera,
would
just so you
intersect
know.
the middle of the
What?
body.
You're on the camera.
But the middle of the
I don't
body.
care, I'm just letting you know.
Make sense? All right. So, abduction and adduction. I am looking up. All right. So for abduction, you're going to ask the patient first to actively move. Bring your arm up towards your ear, whatever command you want to use. You see that she has full motion or close. Once you know that she's achieved that, you can kind of just step inside and set up your landmarks here. You don't have to go from full adduction to do it. It makes it a lot easier for you to be able to line up here as opposed to being like this because you're in the way. So once she does that active range, you can step inside and you can find your landmarks. Now you're going to find the anterior acromion, and you're going to fall off the anterior portion of the acromion just inferior to that, again to project through the head of the humerus. So your stationary arm, your axis of rotation is going to be through the anterior part of the humerus, right? And the one thing that you have to do here, again, is you need to stabilize it to the trunk. So just below the clavicle, you'll feel your first and second ribs. Just stick your pinky there, just something to anchor yourself, because you don't want to have it too far over the body. It's actually going to end up being just lateral to the trunk, if you can see my stationary arm, and it's going to be in line with the trunk. So go anterior of the humeral head, just inferior to the anterior acromion. You're going to anchor yourself with your pinky or on the border of your hand, just to hold yourself in position. And then after they move actively, now you can just go here, take them direct, full passive abduction. And again, you don't have to go further than 180. Just know that they've achieved at least 180 midline of the humerus, and you can say that she's beyond 180 degrees, but she's achieved full range of motion. 180 degrees is all you have to tell us. So once you've achieved that, they've gotten to 180. You don't have to go further. You want to test end field to make sure you're there, but you're just going to tell us they've achieved 180 and even beyond 180 degrees. Okay. Make sense on that? Okay. Common mistakes with this is that people are going to move too much. They're going to move their axis. You're going to be too far medial. Okay, you want to make sure that you're high enough that none of breast tissue or anybody's bodily tissue gets in the way, because it is a common compensation is that your goney ends up being like that. You're not going to get an accurate measurement. So make sure that you're high enough off the body in order to retain pure motion. Okay. Adduction, it's the same setup, but we don't really measure for it because as long as they can come to the body, we know that they have full motion. So if you needed to, you could do the same axis of rotation, same landmarks, but if they're at the midline, they've achieved adduction, because this is not adduction. That's coming into horizontal adduction. So as long as they're at their body, they've achieved their full motion. We're not going to test you for that on the practical. Right? I don't think that's one of the practical things. No?
That's not.
Okay. What do we have next? Intellect now? You guys have internal, external, or horizontal? Horizontal.
It says not responsible for it.
Yeah. I'll give you guys an overview of it just so you know how to do it clinically, but you're not going to be tested on it for the practical. You can set up, Sean. It doesn't need trick.